Good evening, everybody. Dr. Dustin here. It is another episode of the Dr. Dustin Show. Tonight we're going to talk about epidural steroid injections. A very common topic, interesting topic, maybe even controversial topic among the community. And, you know, I think it's time that we have the discussion because it has been, I think that the patient experience with it differs so differently than the physician's experience with it, that is the epidural steroid injection. But it's coming to a head. It's coming to a point where we can no longer practice business as usual. So we're going to talk about it tonight. It's good to be here. I had a very busy day, actually, doing a bunch of epidural steroid injections this morning and afternoon.
Ironically.
You know, it is. So some people might suggest that would imply I know what I'm talking about, and others might use that to say, well, he's just getting paid to promote epidural steroid injections, so why should I listen to him? You be the judge. I don't care. It's just I'm going to say what I want to say. So welcome to the show, everybody. Glad to see you all showed up. I have the chat open here. Welcome, everybody. I was going about my normal business the other day, just my daily routine, when I was looking at my phone and an article came across my inbox, and it was entitled De-Implementing Spinal Injections in Pursuit of Value-Based Care, Rethinking Pain Relief. This was published here in the Journal of Pain. It looks like the lead author being Lindsay Ballingy, I think is how you pronounce that. So more than welcome to look that up yourself. I'm going to read several things from this article tonight so that we can have an insightful discussion on where the epidural steroid injection has. There may be some good things that come from this. There may be some controversial things that come from this. And so we're going to ask you a lot of these questions, the viewers, the people that are living with chronic pain, let's say on a daily basis, or if you turned into this channel and maybe you're first dealing with pain, you have acute spine pain, maybe it's radiating like sciatica, and you're wondering, wait a minute, I thought now is the time I should get an epidural steroid injection, but it's going away. Well, it might be, or at least paid for by insurance. You can always still pay cash, I suppose, for any type of service for a qualified practitioner. But tonight we're going to talk about the insurance reimbursement, the stance on epidural steroid injections. Now, epidural steroid injections, you know, they've been around really for a long time. Actually, they're just about as old as the pyramids. 1952, that's when my father was born. They are as old as my father. So there you go. Shout out to you, Dad. Happy birthday. Back in October. And so, you know, we came up with the epidural steroid injection in 1902, but it wasn't really implemented routinely for chronic pain until 1952. And then, of course, there were several studies that started filtering through the system that showed its efficacy in treating especially radicular type pain. Somewhere along the way, it got, let's say, broadly applied to any type of low back pain. And so we found that, you know what, maybe it's not so good for one type of back pain. Maybe it's really only good for a very special type of back pain, most notably the sciatica type pain. We call it radicular pain or radiating pain, such as pain that goes from your neck into your arm or from your back down into your leg. Some patients deal with thoracic spine pain that sort of radiates around the chest wall, and that can be a form of radicular spine pain. And typically what that reflects is a herniated disc pushing upon that nerve, or a disc injury that subsequently results in inflammation, swelling, and pressure or irritation around that nerve, causing those symptoms. And that's sort of the idea behind doing the epidural steroid injection. It's a targeted approach that can inject steroids and some local anesthetic into that area and help wash away that inflammatory milieu and reduce your pain. So this has been, mainstay for over 70 years now, and to date is probably the most commonly performed pain management procedure in the United States. Now, if we know anything about cost management techniques, in my experience, they don't always go for the most evidence-based approach, or let's say the most fair approach, or let's say patient-centered approach. Usually what attracts the powers at B, what are they targeting first? It's the thing that costs the most money. Now, epidural steroid injections really, they don't pay the physician very much. We talked about this in an earlier podcast. And of course, everything's relative. So, you know, I mean, $100 is still $100. But when you take into account the amount of work that it takes to get to that point, the amount of risk that that physician is taking, and the skills that he or she needs to hone and maintain, $100, let's say, relative to a simple clinic visit, is not that much. A clinic visit might pay $125 or more. And so an epidural steroid injection, of course, depending on where you do it and, you know, what kind of deals you make and that type of thing. But it reimburses the physician, this is on Medicare's website, about $100, depending on the location and type of epidural injection that you're doing. Now, what I found immediately interesting about this article is that they were using the cost or the reimbursement for the procedure as a main incentive that needs to be corrected. So, low-value interventions rarely fade with the introduction of new treatments. Rather, their continued use reflects entrenched reimbursement incentives, provider training norms, and patient expectations. Okay, well, you know, that may be true for some other things, but for an epidural steroid injection, I would beg to argue. Epidural steroid injections, the reimbursement rate for them, not only is it lower right now than a standard clinic visit, which, by the way, is much easier to do and has way less liability associated with it. Okay. The cost of epidural steroid injections has diminished greatly, much like with everything else, but specifically this procedure. I remember when I was in training, I would hear attending physicians tell me back when they were practicing in the early 90s, each epidural steroid injection would reimburse them approximately $2,000. Now, this is anecdotal evidence, so take that for what you will. For some reason, I can't find the actual reference online showing that reimbursement, but it stands to reason. Pain doctors in the early 90s and back when we had this big war against pain and pain became the fifth vital sign, it was a hot specialty to be in. And so not only were prescriptions going out the door like crazy, but also epidural steroid injections really took off. I mean, you can imagine if each injection is paying $2,000 to the physician. And by the way, that's in 1990 money. What is that worth now? Like $4,000, $4,500? Plus the cost of overhead was much lower back then too. So, I mean, that was significant money. You can imagine if you lined up just 10 patients, you know, in a day. That's how these physicians were affording second houses in Colorado and, you know, Utah and boats and, you know, all these crazy things. Now, I'm not arguing that an epidural injection should be reimbursing at that amount. I think that's perhaps a bit excessive, but to say that it's still a main driver in how we practice medicine or make decisions when it's actually reimbursing less than a clinic visit, that to me just doesn't make a whole lot of sense. By redirecting resources away from ineffective procedures and toward evidence-based alternatives, de-implementation offers a proactive pathway to improve outcomes, enhance equity, reduce waste, and strengthen patient trust in pain management. Do you think, now this is a question I have for the audience, because I know a lot of you perhaps have been used and abused by the system when it comes to epidural steroid injections. Maybe you got way too many than you should have. Maybe you were, let's say, coerced into getting an epidural steroid injection simply to justify your ongoing prescriptions, right? That would be an inappropriate way of using this treatment. But let's say that, you know, things were generally applied fairly, and you had a good relationship with your doctor, and your doctor had good rapport with you, and the conversation came up. You're like, hey, you know what? This may help you, but maybe it won't. I really don't know. The evidence is you know, a little bit shaky, and I'm going to come to some reasons why that might be the case. But here's why I think it will work. I've had other patients that this had worked really well for, and by doing this, yeah, it's not going to last forever, but it will allow us to, let's say, participate in therapy a little bit easier, or make sure that you get to your wedding next month, because I know that's very important for you to be there for your children, right? Or whatever the case may be. There may be a short-term, patient-oriented goal that you're trying to achieve with this intervention. Okay, great. Now, let's say, well, the powers that be have reviewed all the evidence, and they suggest that this is no longer effective, and we're just going to take it off the table. So now, as your physician, I am no longer able to offer you this procedure, that is, unless you pay cash for it. Does that strengthen your trust in your pain management doctor? That's just the question that I have. Maybe it has nothing to do with your doctor, but maybe everything with the system. It is our position, this is coming from the article, it is our position that there is no better de-implementation candidate in pain management than the epidural steroid injection. Despite substantial evidence showing limited long-term benefit and strong clinical guidelines recommending restraint, epidural steroid injections remain commonplace across healthcare systems. In the United States alone, an estimated 9 million spinal injections are performed annually, generating billions of dollars in healthcare expenditures and exposing patients to procedural risks without clear evidence of durable benefit. So these statements, again, these are very broad statements. Strong clinical guidelines recommending restraint. Yes, we already live in this world. Medicare and many commercial insurances will not pay for an epidural steroid injection unless it follows a very strict clinical criteria. And in most of those cases, and if not every case, those criteria will include chronic pain that, let's say, has lasted at least 6 weeks. It's not really the definition of chronic pain, but at least 6 weeks in most cases. That is radicular, meaning radiating type pain, like I mentioned before, the sciatica type pain. This is the type of condition that we have the most evidence for the epidural steroid injection. Even still, though, it doesn't last forever. And we know this. Doctors know this, patients know this, and yet it still existed for 70 years. So, what are some of the reasons for that? Again, what we're trying to do is treat an acute pain condition, or a subacute or maybe early chronic pain condition. Now, the longer pain goes, yes, I agree. You're going to have more centralization physiology, right? The brain and the spinal cord become more ingrained in transmitting those pain signals. And so a peripheral treatment like an epidural steroid injection may not be as effective as it would have been if done earlier on in the treatment plan. However, it seems like the reason that they're trying to get rid of all of this is because the treatment just doesn't last, period, across the board. And even though each individual treatment is relatively inexpensive, in my opinion, that's not according to this opinion, when you multiply it by 9 million spinal injections a year, that number adds up. But see, again, this is where they're coming at it from a broad brush and not from a patient-centered condition. I kind of look at this like insulin, right? Insulin's expensive. You're going to need more than one dose of insulin to treat your chronic condition or even your acute hyperglycemia in most cases. Yes, there should be focus on diet and exercise and weight loss and all these other things, but not every pain patient is going to be able to recover from their symptoms based on, let's say, less interventional techniques. So, again, this is painting the system with a very broad brush. Interest in epidural steroid injections surged recently following a high-profile BMJ publication that recommended discontinuing these interventions due to lack of meaningful benefit. So again, this was another big article. This article, the one I'm reading now, seems to be in step with that. Notably, this recommendation was met with significant resistance from clinicians and professional societies. Well, no kidding. I would be okay if the epidural steroid injection didn't exist, because, well, let me put it this way. I would be okay with it if it didn't exist and there was no indication for it. But there are indications for it, and people do get better from it. But I don't like doing it, and I've said that before. It's probably one of my least favorite procedures, because as a business owner, it makes very little to no money. That's just the reality of it. Now, I do it because it helps the patient, the properly selected patient. Oftentimes, it provides a way to prolong surgery, or hopefully delay indefinitely a surgical intervention. I mean, how many times does somebody come into the clinic and they have radiating pain, and you look at the MRI and they're like, yeah, you got a big old disc herniation, you need to do PT. And the patient's like, well, I did PT. Okay, well, I mean, we can try an epidural, but, you know, they don't really do that anymore, so I guess it's just surgery. Well, I don't want to do surgery. Well, I know you don't want to do surgery. Well, will an epidural help? Well, yeah, I mean, it could. I mean, it could, you know, reduce your pain like maybe 50%, maybe, 3 to 6 months if we're lucky. Well, that sounds great. Yeah, let's do that. I'd rather take my chances on a very simple procedure with relatively lower risk than a surgery than do surgery. Makes sense. But that type of medical decision making wasn't a part of this rationale here in this paper, apparently. This controversy underscores a key point for pain care redesign. Successful transformation requires not only having scientific evidence, but also developing means to proactively and systematically phase out entrenched practices. Now, this to me I read as a threat, because if we're going to be like, well, we got to trust the science, and, the physicians, we should respect physician autonomy, but then at the same time, well, they can still have all of that, but we don't want to pay for it, so we're going to be a little bit more proactive. We're going to just kind of force the hand a little bit. And that's what this article talks about. They actually lay out 4 steps on how they force the hand. So let's talk about it. It's a very long article. Bear with me. Here we are. Okay. And in case you're wondering, what is the solution that they keep arguing for instead of the epidural steroid injection? You probably already know, but it's physical therapy and cognitive behavioral therapy, mind-body type stuff. Not to say that those things have no value. I'm sure that they do, but also they have value for the right patient, just as an epidural steroid injection has value for the right patient. The big problem that we have in this country is either or. It's do this and not that, or we're going to take away all of this and you're going to be forced to do that. And inevitably, across the board, somebody gets hurt from it. From a policy perspective, reducing expenditures in low-value injections could free up resources for investments in evidence-based, whole-person care, such as physical therapy, behavioral interventions, and interdisciplinary pain management programs. Hello, we're already doing that. Thank you. Could free up resources. Okay, yeah, I'm sure our government can handle the budget very well. I just paid my taxes. I might be a little bit bitter, but something tells me they're still going to borrow more than they can spend. And then they're going to support this transition to capitated and value-based payment models that reward higher value care. Imagine what a capitated or value-based payment model looks like in chronic pain. I mean, I know fee-for-service has its issues, but imagine if at some point the outcome wasn't achieved, but the finances were terminated. Or imagine if a pain physician only got paid if the patient had meaningful relief of their symptoms. I mean, again, that sounds nice. I understand that from a patient's perspective, but from a physician's perspective or a business owner, that would immediately shut down the business. That would immediately shut down the clinic. Or as Keith put it one time when he was referencing his doctor's approach, well, Keith, I treated your pain. If you're still hurting, that's your fault. That's what this would turn into, by the way. Now, the reason I'm incentivized to treat your pain as quickly and effectively and safely as possible is to build my own reputation in the community. I mean, that's the selfish incentive. Of course, there's a non-selfish incentive, which is to help you out of your pain. But let's be honest. I mean, if all I was doing was milking you for every dollar that you're worth and throwing the efficacy of your treatment out the window, eventually that's going to catch up with me. How do I know? Because it does catch up with my competition. It does catch up with other doctors in the community. How do I know? I get these patients all the time. So, I mean, the incentive is not to necessarily do the fee for service and, bill you out of existence. It's of my opinion and experience that the free market will help to dictate, let's say, how good of a pain doctor you are. But that's another reason why we have this channel, is to bring awareness to this, because, not every patient has that insight or experience when they go to a new pain doctor. They think, well, of course that they're going to, do the very best for me. And that's obviously not always the case. And maybe that's some of the interpretation that these broader policymakers have. They realize that, there are a lot of bad doctors out there. There are a lot of bad clinics out there. And really the only way we can, let's say, reduce misapplied funds is to perform de-implementation techniques, let's say with certain procedures. Unfortunately, good doctors, good clinics, and good patients will ultimately pay the price. So what is de-implementation? De-implementation refers to the process of reducing or stopping the use of health services and practices that are ineffective, harmful, or not cost-effective. What does de-implementation look like? Well, there's 4 steps or 4 ways of looking at it. One is full removal. So the practice is eliminated entirely from routine care, such as ceasing the use of spinal injections for patients with nonspecific chronic low back pain across all clinics. Again, if you want to get paid by insurance, this already exists. Why they're talking about it now, I'll come to. The next one is replacement. So the low-value practice is substituted with an evidence-based alternative. So the example is replacing routine spinal injections with a range of guideline-recommended treatments such as, you guessed it, physical therapy, cognitive behavioral approaches, mind-body interventions, and interdisciplinary pain management programs. Sounds lovely on paper, but again, who is just doing injections and then walking away from you? Let me know in the comments. I mean, I'm sure that exists, but maybe rather than de-incentivize one practice where lots of people will be harmed, how about you incentivize other practices where more people can benefit? I don't know, just a thought. So we have removal, replacement. The next one is reduction. The frequency or volume of the practice is deliberately decreased, often by targeting specific patient populations or clinical indications. For example, using injections only in patients with confirmed radicular symptoms who have failed conservative care. We already do that. Okay, great. We already do that. I mean, we already do that, and there's still 9 million injections. So I don't understand where all the inappropriate injections are being done. How are they getting this approved? How are they getting paid for it? Where are the audits? I know there have been audits and people have had to pay back money, but somehow these procedures are continuing. And the last but not least is restriction. So access to the practice is limited through changes in policy, authorization, or referral criteria. So the example is requiring a second opinion. i.e. peer-to-peer reviews, pre-authorization, or documentation of guideline-based indications before allowing injections. So this is the whole thing about peer-to-peers. They are literally exposing themselves, putting it in black and white on paper as if we already didn't know, but it's right there in the ink. Peer-to-peers are not to increase quality of care, they're to reduce spending. Period. Full stop. We don't do peer-to-peers anymore, by the way, at the hospital. It's a waste of time. Total waste of time. They used to be relatively rare and far between, but it is now affecting almost every single patient that comes into inpatient rehab to recover, let's say, from a stroke or a surgery or you name it. And so pretty much now every patient is requiring a peer-to-peer, which means that I have to take time out of my busy day to talk to most likely a physician of another specialty who has reviewed the chart, apparently, and basically gives me all the reasons, which are, I'm sure, AI-driven, to let me know why the patient should go to a nursing home or just go home instead of doing inpatient rehab. Now, the doctors at the hospital are recommending rehab. The patient wants to do rehab. I reviewed the chart and recommend rehab. And yet the very qualified, very insightful physician that the insurance company pays for gets to come in and tell me no. So I spend 15, maybe 20 minutes arguing, and it goes nowhere. And so this is very, very commonplace now. The hospital and myself, which I largely was a proponent of this, we just stopped doing it. It's a waste of time. If that's the game you want to play, we're not going to play it. We don't have time. Now, if we like won ever a peer-to-peer, if we're like, yeah, okay, you're right, the patient does, then sure, but it's not that way. So what ends up happening now is we just go straight to appeal. The patient and the family go through the appeal process, and in most cases, it's approved at that point. We've gotten more success going that route. But this is my point. They're saying exactly right here, well, we need to reduce epidural steroid injections, so we're just going to require that you have a second opinion. We're just going to make you do pre-authorization. And by the way, we're already doing this. This already exists for epidural steroid injections. And yet we're still getting $9 million a year. Medicare just started doing that this year, by the way, in select states. Texas is one of them. I believe the others are Oklahoma, Arizona, Washington, New Jersey, and Ohio. And what they have done for the first time, really ever, is starting requiring pre-authorizations for epidural steroid injections. Before, if you had traditional Medicare, we could just schedule you, do it, bill Medicare, and then Medicare might audit you, and if you didn't follow the policies, they would demand their money back. So we're still incentivized to follow the clinical protocol and keep our money. That's the whole business of dealing with Medicare. It's not how much you can generate, it's how much you can keep, because they're always looking to take their money back. But now they're requiring a pre-authorization to do an epidural steroid injection. An epidural steroid injection that reimburses about $100. Now I got to pay an employee to sit on the phone or go through some online portal for 15 to 20 minutes to get approval. There's no money in this procedure. I'm just telling you this. There's very little money, if any, to incentivize frequent or even overuse of this procedure. It's not there. I'm telling you, as a practicing pain physician, it's not there. But okay, I mean, these are all the things that they're doing to eliminate the epidural steroid injection, even though apparently we're still getting 9 million injections a year, and we're already doing most of these things. But this is a brand new article, which tells me, again, that there's an increased push against it, and that's clearly exemplified by the fact Medicare now is requiring pre-authorization. What is the controversy with all of these studies? Pain management studies are very challenging to interpret to begin with. Yes, you can have very good studies, and they're still going to have room for doubt. They're still going to have significant flaws or biases that need to be accounted for. When it comes to the epidural steroid injection, I've listed a few things here that should be taken into account, I think, when making these decisions. One is the duration of symptoms. The shorter the symptoms you have, the more likely, in my opinion, and what the evidence shows, the more likely it's going to work for you. And again, that reflects an acute pain process or a subacute pain process where there's an acute inflammatory response, swelling or pressure or irritation on the nerves. And by putting that steroid in there, you're able to cool all that down and significantly improve your symptoms, especially if this is a first-time event. Now, the longer you have pain, the more your body and your brain and your spinal cord remembers this pain, those signals. Secondary messengers are created, new spinal and neural pathways are created, and the harder it is for that pain to go away. Now, that might be a good indication for a spinal cord stimulator, but that's another story. So the best way to prevent chronic pain is to treat acute pain. I mean, that's, hands down. It doesn't sound like duh, hello, but I feel like I need to say it because we're removing so many effective options at the front end. Even in the ER, there's ERs now that are not, effectively managing your pain, right? I mean, I don't have to preach to the choir there, but it's like, no, the best way to prevent chronic pain is to treat acute pain. We need to protect your brain and your spinal cord. We don't want your brain and your spinal cord to sense these really bad pain signals and start creating pathways and remembering it. So, no pain patient is the same. And when you bring something of such high subjectivity into a study, it takes an extreme amount of rigor to find similar patients so that you can measure small differences. But the duration of symptoms, that's a huge category. Are your symptoms acute on chronic? So this is another thing I believe, right? So if you're measuring certain things in a study, right? You're looking at pain score, you're looking at function, you're looking at quality of life. Well, most chronic pain patients don't just have one thing that hurts. Hello? So if you're going into the doctor, let's say you have neck, thoracic spine, and low back pain, and now your low back pain's been there for 2 years, and the other day you just moved and you had to lift a heavy box, and now you have radiating pain down the leg. Okay, well, you might qualify for an epidural steroid injection, but let's say, okay, afterwards you did great. Your pain went from a 10 to an 8. Well, if you put that into the study results, it looks like, we really didn't do much. But what if 8 is your baseline? Right? What if you're functioning always at the baseline? What if you just push through the pain and now you're feeling better, but your function really didn't change? What if your quality of life is really no different because you have other stresses that are contributing to a negative mood or a high stress level or whatever the case may be? There's so many factors. Even when the injection worked for what it was intended to work for, the outcome measures could still be unaffected. And again, a lot of that is just because these outcome measures are patient reported. It's subjective, and everybody has a different experience. The next thing that can cause different or let's say negative outcomes is the severity of injury. Right? I mean, you may have the same diagnosis on paper, but one could be a lot worse than another. The location of the injection. I mean, we have, how many freaking vertebral bodies and neural foramina and different places you can put the injection. Are we comparing apples to apples, or are we comparing apples and oranges? And these are all the things that you need to look for in the study to make sure that we're talking about the same thing. Of course, there's the skill of the injector. Like it or not, this is a skill. It's like you're a surgeon. Some surgeons are better than others. Some know how to hold a scalpel and suture better than others. So that will certainly impact the outcome. The patient expectation. So if a patient goes into a procedure expecting that the procedure is going to work, chances are it will work. That's called a placebo effect. If a patient goes into a procedure thinking it won't work, let's say because they're feeling like they're just being coerced or forced to do this in order to get their prescriptions or whatever the case may be, they have a negative outlook on it, chances are it's not going to work. That's called a nocebo outcome. Again, a lot of these patients that enroll in these clinical studies, a lot of them are already on the severe end of things. A lot of them have already tried a lot of other alternatives. A lot of them may already have negative expectations. So again, it's just so convoluted when you go to try to decipher the conclusions of these pain studies. And by the way, this is what multiple professional societies argue as well. I mean, these ideas aren't just coming from my head. These ideas are coming from the practicing physician, many of which are members of these professional societies. And again, I would argue if it is negative, I mean, the spine pain is very difficult to diagnose. We've been over this before. You got vertebral bodies, you got intervertebral discs, ligaments, tendons, the spinal cord, the dural sheath. You got nerve endings and muscles and soft tissue and skin. I mean, there are so many things that could be causing your pain, and then all of that's got to be filtered by your brain and your life experience. So to just simply point at one thing in the spine and say, well, that's it, it can be very challenging. That's why it's important to do a proper physical exam, to get some advanced imaging, let's say, like an MRI or a CT scan. Maybe you should get a nerve study like an EMG or nerve conduction study. And then even if all of that doesn't kind of paint the picture of what's going on, epidural steroid injections themselves can be diagnostic. Well, it looks like that nerve is the problem based on everything that we've come up with so far, so we're going to inject it. And if I inject it and it gets better, well, by golly, that must be it. Now you cross your fingers and see how long it lasts. Could last a long time, maybe not. But if you only have to repeat that injection once a year, well, by golly, that's better than surgery. So you see, there's so many different ways. Even if the injection is negative, it still provided value. It said, guess what? That's not it. That nerve did not respond to this injection. It looked like it should have responded, but it didn't. Okay, well, there's value there. And again, keep in mind that I am arguing for a procedure that puts me at significant liability risk that pays less than a visit in the clinic. So it's not because I just am getting rich off of epidurals, quite the opposite. So, I think that's sort of what wraps up the idea that there is apparently a coordinated effort to reduce the number of epidural steroid injections in this country. And if nobody else online is calling it out, I will be the first. And I'm already going to get comments, well, it should be done away with. My doctor put me through 10 of them and none of them worked. I hear you. Probably you shouldn't have had more than one or two at the most, if that. But the point I'm trying to make is that it does work for the right patient with the right expectation of goals and outcomes. It can facilitate a diagnosis. It can facilitate participation in physical therapy or other exercise-based therapy. And I don't see a purpose to totally eliminate a treatment option for a patient that may be life-saving. I mean, just in my immediate circle of family and friends, I can think of probably 5 people that do very well with one injection, perhaps once a year or every 2 years. They do very well with it. What's the alternative? Surgery? Talk about expense and risk. What's the alternative? Medication management? Talk about risk. But this has been sort of the whole approach that, the powers that be, they take with everything. Well, opioids harms a certain number of people, so we're just going to really make it difficult for you to get opioids, period. Okay. Or, we used to do a lot of discograms in the past. Discograms is where you inject the disc and you try to identify if that disc is causing pain or not. And, they said, well, same kind of reasons here. It's not worth the cost. Okay. The problem is that this type of approach, like I said, we're already doing all of the things that this paper is arguing for, except total elimination. But we already do PT, we already do CBT, we already do mind-body stuff, we already do interdisciplinary pain management. We've already significantly reduced the number of procedures that we do in the clinic. We already restrict it. We're already doing PAs. We're already doing peer-to-peers. It's not worth it. It's already not worth it. It's already not worth it. And yet, apparently, we're still doing $9 million a year. That must mean that at least a few people are benefiting from it. Now, I would challenge other pain management physicians to not rely on the epidural. And that is one thing that I agree with this paper when it comes to the training. If all you have is a hammer, all you're going to do is hammer. So, get better. If you want to keep certain procedures and medications and treatments around and available in your toolbox for your own patient's sake, do better. Learn some new techniques. Learn some new treatments. Integrate some alternative treatment pathways into your program. Bring on different doctors. Bring on psychology. Maybe learn how to do, spinal cord stimulators. Maybe learn how to do peripheral nerve stimulators. Maybe learn how to do a minimally invasive spine fusion or sacroiliac joint fusion. There's good evidence behind it. And guess what? It pays better than an epidural steroid injection. And no, I'm not saying do this on every patient indiscriminately. But if you don't approach a patient as an individual that has individual needs and individual treatment approaches, then our governing powers are just going to operate the same way that you do, with a broad brush. And then in that way, not only does your clinic get harmed, if all you do is epidural steroid injections and they take it off the table, what are you going to do? Write meds? I doubt it. What are you going to do? Become a psychologist, apparently, because that's the only thing that they're going to pay for anymore. So do better. That's the encouragement I have and the challenge I have for pain management physicians. If all we're going to do is hammer something when maybe it needed a screwdriver or it needed, you name it, some type of bracket, I don't know. You need to be able to be skilled in those things. And I would argue for the maintenance of ongoing epidural steroid injections, even though I hate doing them, because they do offer patients meaningful relief, even if it is short term. And that can be meaningful in and of itself. That can get you from point A to point B. I don't know what point B looks like, but if it's surgery, let's put that off for as long as we can, huh? All right. Well, that's my 2 cents. I'm so curious to get into the chat. For those of you on the live, this concludes the end of this video, and I will see you next time. Now, if you're still here, let's talk.